May I request Dr. Jyoti SHEORAN to present her paper on ganglion cell complex thickness as a structural biomarker for visual outcome in optic neuritis.
Good afternoon. Yes, yes. I'm Major Jyoti. I'm presenting the paper, The Role of Ganglion Cell Layer in a Plexiform Layer Thickness as Structural Biomarker of Visual Outcome in Optic Neuritis. Optic neuritis is defined as inflammation of the optic nerve caused by damage to the protective myelin sheath, which is surrounding the optic nerve with an idiopathic etiology. Mostly unilateral, presenting in the age group of 15 to 58 years, has shown female preponderance. Optic neuritis patients present with a triad of visual loss, pain on ocular movements, and dyschromatopsia. The diagnosis is usually clinical. However, certain investigations like VEP, OCT do provide us supportive evidence. Most research in these conditions have been focused on peripapillary retinal nerve fiber layer. However, recently some studies have suggested that ganglion cell layer and inner plexiform layer complex measurements at macula may be more accurate and reliable biomarker of the final visual outcome after an acute attack of optic neuritis. Macular IPL thickness demonstrates a more accurate relationship with visual acuity or visual field, as it is unaffected by acute optic disc edema, has no large vessels, is unaffected by refractive errors, and has less subject variability. Measurements can be taken immediately, whereas in RNFL, it takes more than a month for the edema to resolve. Although thinning of GCL IPL and nerve fiber layer follow the same trajectory, it has been seen that the nerve fiber layer thinning occurs later than the GCL IPL thinning, and mostly it occurs during the first 2 months. And considering the fact that macula contains approximately 50% of the retinal ganglion cells and optic neuritis tends to affect the central visual field, GCL IPL measurement might detect early structural loss. So the study was conducted. It was a prospective cohort study done over 18 months in 25 eyes. The age group was 18 to 50 years, presented with unilateral acute demyelinating optic neuritis. The exclusion criteria excluded myopia, hyperopias, extreme hyperopias, astigmatism, dense cataracts, patients with other causes of ganglion cell loss like optic nerve drusen, glaucomas, and other causes of optic neuropathy, bilateral optic neuritis, recurrent optic neuritis in the same eye as in case of multiple sclerosis. A detailed history was taken. The vision was recorded with logmar visual acuity, refraction, slit lamp examination, the pupil size, intraocular pressures, then the complete fundus examination was done. Color vision was done using SHEORAN and contrast sensitivity with Pelley-Robinson's chart. Flash VEP was done in all cases to aid diagnosis. SD OCT was done. It was done using the scan 6 into 6 mm area at the macula. GCL IPL thickness measurement was done by taking the segmentation scan, and RNFL thickness was done using a ring scan. The analysis was done with 8 of the macular ET DRS sectors, excluding the central 1 mm of the image. After diagnosing, we started with the pulse steroid therapy of 100 mg dexamethasone over 1 to 2 hours for 3 days, followed by oral prednisolone 1 mg per kg for 11 days. The calculation was done using the student pair t-test. Binary logistic regression analysis was applied. The observations and the results: most patients were in the age group of 19 to 40 years in our study. The distribution was similar, in our study, it was similar in both sexes. More than half of the patients presented to the clinic within 3 days of onset of symptoms, whereas 76% presented on the day of 6th of onset of symptoms. The most common complaint was diminution of vision. Both visual acuity and the contrast sensitivity improved significantly after starting the pulse steroid therapy as measured on day 30 and day 120. We did the comparison with the other eye. The changes in the visual acuity in the optic neuritis patient. Significant improvement of visual acuity was seen from day 0 to day 30, and improvement between day 30 to day 120 was insignificant. The comparison between the contrast sensitivity between day 0 to 120 Contrast sensitivity improved significantly from day 0 to day 30, and improvement between day 30 to day 120 was again insignificant. Significant thinning of GCL IPL layer was seen in the eyes with optic neuritis. When we compared it with the other fellow eye, the similar changes were seen, and the inter-eye differences increased from day 0 to day 30, and from day 30 to 120 was again insignificant. The correlation was drawn between GCL IPL thickness and visual acuity from day 0, 30, and 120, and a slightly positive correlation was observed between the visual acuity and the GCL IPL thickness. The GCL IPL thickness was also compared with the contrast sensitivity, and positive correlation between the GCL IPL thickness and contrast sensitivity was seen. So the discussion, the mean GCL IPL thickness showed a significant decline starting from the first visit up to the end of the observation period. The greatest change, however, was seen at the end of the first month since presentation. Presence of peripapillary axonal swelling makes the acquisition of maps difficult. This implies that the significance of using GCL IPL thickness map as an early biomarker for early axonal injury in cases of acute optic neuritis.
But I need to sum up quickly because you're over time already.
Sir.
They have negative marks for over, right?
More is the GCL IPL thinning, more is the vision loss. Therefore, GCL IPL thickness monitoring will help. With the help of SD-OCT can be used as a biomarker for final visual outcome in patients of optic neuritis. Thank you.
You can ring the bell for the timer. Yeah, but it's going on in the corner. Yeah,
On the top.
that's what I told
see
you, on the right
screen,
corner. Yeah.
Right. Yeah. Any comments?
So are you saying that GCIPL can be a marker for acute optic neuropathy? When the optic neuritis is just happening.
Yes, sir. Matlab, we can monitor a patient. That is a more stronger marker to tell us how much is the visual outcome going to be end of the treatment for the patient.
So it's that's why the title was a little misleading, and I think that's what we were thinking about. So biomarker for prognosis. So won't use the word biomarker. It's a prognosticating investigation is essentially what you're trying to say, that the effect on the GCIPL can help us to prognosticate the final visual acuity of this episode of optic neuritis.
Yes, sir.
These were all multiple sclerosis, or
No, they were not multiple sclerosis. They were MS was ruled out to
so
include.
what was the cause of the optic neuritis in these cases?
So it was usually idiopathic, and we.
Like I said, what else have you ruled out? NMO MOG was done in these patients?
Yes, sir.
And they were all negative for NMO
All
MOG?
negative, sir. MS was ruled out in every patient.
I'm not actually so concerned about MS. I'm more concerned about NMO and MOG, particularly NMO, because NMO has been known to be very early affecting the GCIPL. So, that may be one of the confounders. If they're all NMO MOG negative, that's fair enough.
How do you say that's a good prognostic indicator? Did you correlate your final visual acuity with your initial GCL?
Yes,
thickness?
yes, ma'am, we did that.
So at the baseline, you did it.
And at the presentation day, ma'am, and at day 30 and day 120, when we compared the results, it was that people who have present at day 1 and are started early on treatment, they have good results with the GCL IPL thickness, and it's a good prognostic marker that way.
Okay.